James Lamberti. I'm a pulmonary critical care doctor at Inova Fairfax Hospital in Falls Church, Virginia. I'm representing the Respiratory Compromise Institute. We decided that we wanted to evaluate what happened to patients that developed respiratory failure after they were admitted to a hospital. We decided to use an administrative database, so we used a large Medicare database and found out that that problem, patients developing respiratory failure after admission to the hospital, was quite common. The number that we got was an estimate of about 110,000 patients annually. What we found was that their outcomes were significantly worse than those patients that were admitted to the hospital and respiratory failure was diagnosed at time of admission. So essentially, patients that developed respiratory failure in the hospital did significantly worse than those patients that had respiratory failure diagnosed at time of admission. Almost 1/3 of patients that developed respiratory failure after hospitalization died in the hospital, and almost another 15% died in the 30 days after hospitalization. This was an administrative claims database, so we can't draw conclusions in regards to why this occurred. What we think needs to happen is we need to evaluate this group of patients to see, are we not making the diagnosis soon enough? Are there monitoring techniques that we can use to try to find these patients before they develop respiratory failure? I think we need to realize that we're not making the diagnosis of respiratory failure soon enough. And we know that from other disease states. For example, sepsis has really been revolutionized over the last 10 years, mostly because we are diagnosing it earlier and doing things sooner. There's actually a very similar study in acute myocardial infarctions, that if you come to the hospital and are suffering an ST segment elevation myocardial infarction, a heart attack, your risk of dying is about 4%. If that heart attack occurs after you've been admitted to the hospital, your mortality is 40%. What we are hoping is that a similar analysis of the patients that develop respiratory failure after hospital admission will lead to a change in how we take care of these patients. We only looked at Medicare beneficiaries, so most of the patients were over 65, but you can have Medicare and be under 65 with disabilities. What we found was it wasn't lung patients necessarily, it was patients with underlying diseases and multiple diseases. So we found congestive heart failure, atrial fibrillation, acute kidney injury occurred in these patients, and I think we may not be thinking of respiratory failure early enough in patients that don't have an underlying lung diagnosis like COPD. I think what we need to do as a community is to start to understand these patients better and not just accept what is occurring as natural. That I think we can do a better job defining this group and making earlier interventions.